I think, as most of us know, psychotherapists and psychoanalysts have helped many people over the past century, but we've also made our mistakes, and I want to think about that today. I recently presented at a psychiatric conference in Australia with Alison Clayton on detransition, and we both received supportive feedback and also some critical comments, and I was especially shocked that my gay colleagues and friends were quite critical of me. And one colleague said to me, "It's too early to do this. You need to leave it alone so that trans can gain acceptance like we did before you start asking these kinds of questions." And other people said they would no longer refer patients to me. So I want to try to disentangle how same-sex attraction and trans have become very confused and conflated in this whole discussion. And I think there are similarities that are important to think about, but there are also substantial differences. I also, most importantly, I want to use this talk to debunk the notion that thinking about the psychodynamics of trans identity necessarily means you're doing conversion therapy. And by psychodynamics, I mean the kinds of things that Stephen Levine was talking about. We're not talking about anything weird or complicated, but about trying to understand the antecedents to somebody's experience. So I'm showing some examples of how the kind of conversion therapy accusation is being weaponized to discredit my work and the work of others. Here, Drescher is referring to work by Stephen Levine and Xenia Abruzzese and me, and says the analytic attitude is reminiscent of conversion therapy approaches practiced by groups like NARTH, the National Association for Research and Treatment of Homosexuality, which was founded by the late Charles Socarides, and this is going with Drescher's comments, whose positions on homosexuality could be interpreted as not caring how many gay people they hurt if they managed to create a few straight people in the process. And he's arguing that that's what we're doing. You know, we don't care how many trans kids we hurt as long as we create a few cisgender ones in the process. Then there are also Psychotopoulou is also a very prominent analyst in this field who has written extensively about trans, and things like this are associated with her. On one of her blogs, she writes about herself that she detests transphobes, even the gay ones, that's me, specifically. Asking the question why of non-normative sexualities and genders too often occurs in the service of illuminating their origins in order to cure and effectively eradicate them. Etiological quests function as stealthy starting points for the motoring of conversion therapies. And she's also said that, where are they? The Evanses and me, we're basically eugenicists, and our intention is to eliminate transness altogether. And more recently, I was described by an analyst in the US as the worst fascist propagandist psychoanalyst in the world. So, in a public seminar. So why I'm putting this up is because I'm annoyed, but also because, because I want you to listen to the moral tone and the absolute certainty with which these comments are being made. And the intention is clearly to discredit and cause damage. And I think Hilary Cass made an important point in her Cass review that there are extreme positions on either side of this debate, and many claims that are not supported by data are held with absolute conviction. And this is a quote from a paper by Friedman and Downey, who were reviewing the history of psychoanalytic bias against homosexuality, which I think we should all really think about. We may believe that we are currently on the moral high road, but it is well to remember that psychoanalysts of past generations who were well-trained, intelligent, diligent, and empathic believed the same. So is trans the new gay? Is it really the same thing? We just need to do what we did with homosexuality in the late 20th century and now apply that to trans. I mean, as we know, psychiatry has a very troubled history of doing harm to many gay and lesbian people. David Schwartz, a US analyst, described this as a moral and intellectual debacle. And in the mid to late 20th century, many psychiatrists and the majority of psychoanalysts believed that homosexuality was always the result of psychopathology. And clinicians attempted to correct homosexual orientation via medical interventions and also coercive psychological practices, which harmed patients. And this history is often invoked as a warning that we should not repeat past failures when it comes to trans. And unless we see trans identities as always an expectable manifestation of human gender diversity, we risk repeating the injustices and harms that were inflicted on gay people in the 20th century. This time, though, the medical establishment claims to be on the right side of history, fighting for the full depathologization of trans and for widespread access to gender-affirming interventions. And anybody who seeks to explore the psychodynamic formation of trans identities is equated with those who tried to cure homosexuality. And as I said before in the quote that I read out, exploratory psychotherapy is really just covert conversion therapy. So just to give you a flavour of how noted and influential clinicians were writing about homosexuality in the 20th century, this is a quote from Edmund Burglar, who was one of the most influential analysts at the time on this topic. Homosexuals are essentially disagreeable people, regardless of their pleasant or unpleasant outward manner. True, they are not responsible for their unconscious conflicts. However, these conflicts sap so much of their inner energy that the shell is a mixture of superciliousness, fake aggression, and whimpering. Like all psychic masochists, they are subservient when confronted with a stronger person, merciless when in power, unscrupulous about trampling on a weaker person. The only language their unconscious understands is brute force. So, I'm using this illustration to give you a sense of what was going on, and this was 1957, but this kind of thinking persisted for a number of decades afterwards. I probably won't spend too much time on this, but the main analysts who were influential when it came to homosexuality were Sandor Rado, who basically believed that homosexuality was a fear of heterosexuality that was related to childhood disturbances. And he also believed there was a failure to identify with the father that led to a deficient superego. So it kind of meant that homosexuals had sociopathic tendencies because they had a deficient superego. Edmund Burglar. Similarly, all homosexuals display pathological dynamics, psychic masochism, a fear of women. It goes on and on. And Charles Socarides, one of the most noted analysts who was associated with the organisation NARTH that I mentioned, said that half of homosexuals have concomitant schizophrenia, paranoia, are latent pseudoneurotic schizophrenics or are in the throes of a manic depressive reaction, and the remainder are neurotics or suffer from character disorders, psychopathic personality, or some variety of addiction. I found this very interesting. The Rorschach, was in common usage during much of the 20th century, and there was an attempt to find signs on the Rorschach that could detect homosexuals, and it was William Marshall Wheeler did some research on veterans, and kind of came up with what were known as the Wheeler signs, which he believed could identify homosexuals, and he thought this could be quite useful in military settings to distinguish a genuine chronic homosexual from someone feigning homosexuality to obtain discharge from the army. And the Rorschach was of practical value to army psychiatrists who may be confronted either with simulators or soldiers accused of homosexuality, which they deny. And I found this very interesting. Patients were identified as homosexual by their therapists based on their own reports of homosexual experience, or the patient's report that he had masturbated at some time in his life, or the therapist's opinion that the patient had a somewhat effeminate appearance or manner, or an indication that the patient felt hostile towards the mother. So if you had any of these features, you were classified as a likely homosexual, and then this was correlated with the Wheeler signs. So 20th century psychiatry and homosexuality, I mean, psychoanalysis was probably the dominant force that shaped mainstream psychiatry for much of the early to mid 20th century. And so we see that in the DSM-1, homosexuality was classified as a sociopathic personality disorder. DSM-2, it was classified with sexual deviations and perversions. But emerging empirical evidence increasingly contradicted this view, and I guess the most notable finding was the data that Kinsey produced in 1948, which basically showed that homosexuality was much more common than anyone had thought. And this is what is particularly striking, and I think we should think about this as a parallel to what's going on now. His findings were met with hostility by psychoanalysts, by the mainstream, who resisted change for decades. It took 25 years before psychiatry, that is the APA, voted to remove homosexuality from the DSM in 1973. And those who challenged the mainstream approach to homosexuality received hate mail, including from prominent educators. Sounding familiar? Another researcher who challenged what the kind of mainstream view of homosexuality was Evelyn Hooker, who looked at the Rorschachs and found that blind raters were unable to tell the difference between the Rorschachs of non-patient gay men and straight men. And there was much more research that followed that also debunked the notion that homosexuality was intrinsically pathological. But as I said, it took a very, very long time before these scientific findings resulted in any significant change. So I'm going to highlight how the same kinds of group processes and strategies are being used now in relation to what we are seeing in terms of the rejection of scientific data in relation to trans and gender dysphoria. And so there are four arms to this approach: propaganda, attack the individuals, attack the science, and claim expertise that cannot be challenged. So homosexuality, the people that refused to accept the scientific findings dismissed it as homosexual activist propaganda. And as we've seen in terms of the kinds of hostility that is directed towards SEGM, we are seen as just really in the throes of conservative activist propaganda. They attack the individuals. So the people who wanted to kind of depathologize homosexuality were devalued as being not psychoanalytic, which was really an insult. It kind of meant that you were inferior or intellectually naive. And with gender dysphoria and trans, we see that if you raise questions, you're devalued as transphobic promoters of cisnormativity. Again, kind of like a certain kind of ignorance in a way. The science was attacked. So the science was dismissed when it came to homosexuality because the argument was, well, many psychopathologies are common, so what? Just because lots of people are same-sex attracted, that doesn't mean anything. With gender dysphoria, we see that the science is dismissed, and the argument is that most healthcare is based on low-quality evidence, so what? The science with homosexuality was argued to be flawed because it didn't take unconscious factors into account, so it was kind of worthless. And we also see the argument that the science about gender dysphoria is flawed because it's looking at the wrong outcomes. We shouldn't be looking at mental health outcomes. Attack the science also involved with homosexuality that the argument that it was irrelevant to the consulting room where the analyst had a superior understanding of the patient's unconscious conflicts. Now, when it comes to gender dysphoria, we hear that it's irrelevant to the science is irrelevant to the consulting room because the gender clinician knows when treatment is medically necessary. And there is a claim to expertise that can't be challenged. With homosexuality, it was all about the psychoanalysts, and psychoanalysis relied on case studies, not empirical data, meaning that the expertise of analysts could never be tested or challenged. And with gender dysphoria, gender-affirming care relies on consensus guidelines created by self-appointed experts in the field. And it's, as we've seen, it's completely resistant to challenge even by rigorous systematic reviews. So just a brief summary of conversion therapy. Conversion therapy, the term it was originally intended to apply to treatments designed to change sexual orientation. And without going into a lot of detail, there were many ways that this was done, including medical, religious, behavioural approaches. Interestingly, estrogen therapy was one of the treatments that was sometimes used for male homosexuals, and it was used as a form of chemical castration, as it often totally suppressed sexual desire. But I want to focus on psychotherapeutic or psychoanalytic conversion therapy specifically. So the main thing I want to point out here is that what people were promoting in the 20th century was a significant departure from established standard psychotherapeutic approaches. These were some of the recommendations. Clinicians should use their authority to actively discourage homosexual behaviour and encourage heterosexual behaviour. There should be outright prohibition of homosexual behaviour by the clinician. There should be education about the pathological nature of homosexuality. And remember, these are analysts who are recommending these kinds of approaches. There should be repeated interpretation of the defensive functions of the patient's sexual behaviours. And they also said that if you make no comment, the patient will see that as tacit approval, and that's very problematic. You should threaten termination if the patient isn't trying hard enough, and that means if the patient is not going on dates with women, etc. That you should give advice on how to approach women, how to go on dates, how to have sex with women. And again, this approach violated fundamental principles of psychotherapy in that it actively encouraged coercion and therapist influence, which is completely against the very fundamental values of any kind of psychotherapeutic approach. So when it comes to trans, we have kind of two polarized understandings. And one is, I mean, there are actually, as we've seen in this conference, there are many ways of trying to make sense of gender diversity. But one is that trans is a natural and normal expression of gender diversity. And the bad way of thinking about it in today's climate is that trans is due to other psychological issues such as childhood experiences and underlying psychodynamics. So as I've said, opponents argue that looking for the psychodynamic underpinnings of a trans identity inherently assumes that the identity is pathological. And this has somehow been forgotten about, but that is a complete misunderstanding of psychodynamic theory. Psychodynamic origins are woven into all aspects of human experience, and this includes healthy as well as psychological functions. And so just the fact that we're trying to understand why somebody feels the way they do does not imply pathology. And, further, all behaviours and experiences are shaped by a range of factors. In addition to psychodynamic conflicts, there are adaptive aspects, including the satisfaction of needs and the search for meaningful interpersonal connection. So there may be many reasons for that lead to a trans identity. And as we've seen, I think Stephen spoke about it as being a creative solution to complex underlying difficulties. And instead of being pathologizing, psychodynamic understanding can be enriching for our patients, adding texture, nuance, and complexity to individual gendered experience. Expanded self-awareness helps clarify the meaning and function of symptoms. As this occurs, new, more liberating solutions can be generated and distress hopefully diminishes. I'll just skip over that. So, homosexuality and trans, are they similar or different? I think in our current discourse, they're assumed to be similar. that is, expressions of sexual and gender diversity, and so therefore the treatment should be the same. Treatment should affirm the patient's authentic self, whether it be their sexual orientation or gender identity. What I'm arguing is that they are similar in some ways, but they're also significantly different. People experiencing distress about gender or sexual orientation are internally divided. I said this, I think, a couple of days ago. They're struggling with an ambivalently held, feared or hated part of the self. And I think we've probably all known or worked with gay people, some gay people who experience same-sex desire as shameful or an unwanted part of the self, which we would have called ego-dystonic homosexuality. They may adopt the heterosexual behaviours and role that they understand to be acceptable in our culture in an attempt to eliminate this part of the self. We now call this internalised homophobia, which is an internalisation of the negative cultural attitudes and hostility to same-sex desire. And in the past, many gay men, in fact, sought treatment to try to rid themselves of this part of the self. So gay affirmative therapies evolved to help people accept this ambivalently held or unwanted same-sex desire. And for some gay patients, the self-hatred they feel is a condensation of problematic developmental experiences that occurred in childhood. And I'm quoting here from a really interesting paper by Friedman and Downey written in 1995, where they were writing about some gay patients who received kind of gay affirmative therapy but unexpectedly deteriorated. And what they were arguing was that the self-hatred that seemed to be about same-sex attraction was actually about a whole range of deeper, more complex issues that all got kind of attached to the same-sex attraction. And the way they describe it is that these experiences may be packaged under the label internalised homophobia, where the unwanted sexual orientation is a carrier for other psychological difficulties. And so people with adverse developmental experiences or primary psychological difficulties may attribute all negative feelings about the self to being gay or lesbian, making sense of lifelong experiences of alienation and psychic pain. This is also sounding familiar, I think, to many of us who work with young people with gender dysphoria. And so the therapeutic approach they recommended involves helping the person accept their same-sex desire and dealing with the deeper issues which have fused with the unwanted sexual orientation. And they noted that unless you do that, the patient will continue to suffer and there won't be a psychological improvement. So I kind of see, and again, there's no universal formulation here, but my sense of many people I've worked with gender dysphoria is that they are internally divided as well. And they're struggling with a part of the self that evokes shame, fear, disgust, or self-hatred. And so I see this as an example of a similar phenomenon where gender is the carrier for unwanted parts of the self and provides a way for the individual to disavow, distance, or dissociate themselves from those aspects of self that they cannot tolerate. These unbearable aspects form an amalgam with the unwanted gender. And psychotherapy bridges internal divisions. The aim of treatment is to help the patient reclaim and bear those feelings and self-states that they're trying to rid themselves of. And if all goes well, the person will have greater access to themselves, will no longer be haunted by painful affects, and will no longer need complex psychological defences to maintain internal equilibrium. It's possible that after this kind of work that transition may no longer be felt to be necessary, or if it is, the patient will hopefully be psychologically healthier and therefore better able to face the challenges of transition. So I kind of think that gender dysphoria is in fact more like ego-dystonic homosexuality in terms of its psychological phenomenology. And with homosexuality, we help the patient accept this unwanted part of the self and face and manage the difficult shame and painful feelings that go along with it. But with gender dysphoria, at least the affirming model is about helping the person distance themselves from the pain-infused part of the self. This is the underlying premise of gender-affirming interventions. And I think Marcus and others have talked about, and many others have talked about in this conference, the way that this kind of bypasses actually making contact with the pain, and it kind of helps the clinician and the patient avoid it. And my concern about this is that it can fortify internal divisions and work against integration and self-acceptance, which are fundamental to all psychotherapy. And I think this could explain the failure of gender-affirming interventions to result in meaningful psychological improvement. You can't eliminate a part of the self. It will continue to make itself known via ongoing distress and symptomatology. So with gender dysphoria, aren't we really, in some cases, colluding with a wish to eliminate a part of the self? And wasn't this what medical and psychological conversion therapies attempted to do with homosexuals? So, I mean, as Xenia talked about on the first day, the availability of gender-affirming interventions drove the demand for a concrete solution to pain. And I think it's probably particularly attractive to young people whose capacity for reflection is still evolving. But this kind of made me wonder how many gay men and lesbians would have taken a drug to make them straight if it were available. Probably a lot. So this is my second last slide. The problematic and harmful ways of working with gay people persisted for decades, despite what the empirical science showed. Arrogance or claims to superior knowledge, coupled with the rejection of science, block the consideration of new information that leads to theoretical revisions and safer, more effective clinical interventions. Then with homosexuality, and now with gender dysphoria. Many gay people, men in particular, received treatments that failed to help them, and some were harmed. At present, we don't know how many young people will be helped, how many will obtain no benefit, and how many will be harmed by gender-affirming interventions. Claims of misinformation have been weaponized as part of a relentless attack on what the science is increasingly telling us via multiple systematic reviews. And SEGM, as the most prominent voice raising concerns about gender-affirming care for youth, has come under increasing attack. With escalating false allegations, we're labelled as a hate group, spreaders of pseudoscience backed by right-wing Christian, white supremacist or fascist ideologies, and driven by a covert anti-LGBTQ agenda. And just finally, I think mainstream clinical thinking is once again being confronted and colliding with the emerging science. And despite the conscious desire in our culture to do things differently this time and protect sexual and gender minorities, we're actually creating a repetition of our history of harming sexual minorities. And so I would just say to close, if history has anything to teach us, it's that we ignore science at our own peril. And one final comment from David Schwartz. The telling of history is part of the present. We must know it correctly to go forward cleanly. To know it in its ugliness may immunize us against its easy repetition. Thank you.